What we are sharing today is a single-center retrospective observational study of a domestic scoring balloon. Why do we want to do this? I think this work is quite meaningful. Although our PPT has just been shared at the Asia-Pacific Conference, I still added a few slides. I still want to talk about the background of this research. When we shared the initial 6 months data last year, we had already presented the DK scoring balloon to all of you at that time. This balloon is specifically designed for vascular access maintenance, and we put a lot of thought into it. Each scoring balloon has different characteristics. It isn't a copy of another product. It has its own thoughtful features and innovations. I won't go through every single detail listed here. I'll only share what I consider more important. Firstly, the scoring element for vascular access maintenance must be sharp, must be strong, the focal pressure is high enough, and the surface area is relatively small. Because vascular access lesions are mainly resistant lesions, hence the more concentrated the force is around the area, the better. In this way, the focus pressure will be greater for the same pressure. Secondly, the height of the scoring element must be sufficient. That is the same as the image here. Our intima is not the intima of arteries. Doctors who have performed surgeries and those who have used ultrasound examinations all know this. You can see the height of the intima is very high, basically 0.5 millimeters or even 1 millimeter, such a high scoring height on the intima. If you wanted to tear in a regular or relatively regular pattern and generate as few flow-limiting dissections as possible after tearing, this scoring element must have a sufficient height. Of course, an excessively high scoring height can also bring additional risks. Factors like the shape and height of the triangle have to be comprehensively evaluated. At least now, DKutting is the tallest among the existing metallic scoring element products. The other is the difference between fixed element and floating element. Personally, I still prefer fixed element, and DK's is fixed at 120 degrees. I am not saying that its fixed 120-degree design is what results in a good expansion effect seen in the image. That effect stems from what I mentioned earlier, the distribution at an average of 120 degrees. Because in regular hyperplasia, the resistance of this circle of blood vessels may not be uniform. Some blood vessels are strong, and some regional blood vessels are weak. If it is a floating element, and if the stenosis is very complex, or during a C-shaped dilation, the floating element may be biased to one side. If just three or several of the floating scoring element is biased to the toughest side, there is still a possibility that the lesion cannot be dilated. If dilatation fails, the lesion will fail to be treated. If dilatation is successful, it's likely because the plain side of the balloon, which is the side without the scoring element, was effectively opened by pressure. But we hope that we have incisional injury more than barotrauma. And with an average angle distribution of 120 degrees, this ensures that to the greatest extent possible, an incisional injury, specifically a tear, can occur. In fact, this image was previously shared AVG's venous anastomosis. The image on the left is before angioplasty, and the one on the right is after angioplasty. So I believe that although there is no obvious scoring mark, in most cases we find that the immediate lumen gain and the vessel wall appear relatively regular. Even if there is extravasation, a tear, or the formation of an aneurysm, it tends to be a predominantly longitudinal tear rather than an irregular transverse rupture. This is actually more important for the patency of the vascular access. First, after dilatation, the vessel diameter should be improved. Even if the dilatation results in an aneurysm, as long as it is a controlled aneurysm, the outcome might in fact be preferable, as it might significantly delay the onset of restenosis. These 2 points have been shared before. Sometimes C-type dilation is indeed necessary, which is also a key design consideration for the DKutting balloon. With previous fixed scoring elements, Achieving this was very difficult. DKutting spring design ensured that the scoring elements can be adhered to the balloon surface like a spring. This allows the inner curve to shorten and the outer curve to lengthen like a spring during C-type expansion. I truly believe that this balloon is independently developed in China. It is not a copy but has its own distinct characteristics. Second, to share our single-center data, it indeed performs better than previous POBA treatments and conventional ultra-high-pressure balloons. In my opinion, our 6 months data have already been published. In fact, what I shared this time was a 1-year data, which were finally summed up. This is a retrospective study and, of course, has many limitations, but it does represent real-world experience with a relatively large number of cases. Therefore, I still hope to present it, share some insights from our single-center experience during the talk, and hopefully provide some inspiration for everyone. We can discuss further later. As you can see, there were a total of 428 cases, 248 AVF cases, and 180 AVG cases. Our enrollment excluded cases involving central arteries, central veins, drug-coated balloons, stents, and other scoring balloons. Essentially, the included interventions were either scoring balloon angioplasty alone or in combination with high-pressure balloon. Regarding follow-up, since this is a real-world study, the more compliant patients were enrolled in our active follow-up system with regular visits. For patients with relatively poor compliance, follow-up was mostly symptom-driven. For example, we would call to check, or the patient would only come when experiencing issues. It is the characteristics of these two subgroups. Let's first look at the AVF group. Most cases involved 1 to 2 lesions, and the majority used 1 to 2 balloons. The diameter of the balloon we use is relatively large, mainly 6 millimeters and 7 millimeters. Most patients in the AVF group had either no prior intervention or had undergone intervention once before. For the AVG group, as everyone can probably guess, the main lesion sites are unequivocally the puncture site and the outflow vein, specifically the puncture site and the venous anastomotic site. These are hemodynamically stressed sites subjected to repeated use. Therefore, for AVG, it is always these two sites, and our balloon applications were also focused primarily on these two sites. Most of them are 1, some of them are 2, and very few of them are even less. For AVGS, since we primarily use the 6 millimeters balloons and occasionally 7 millimeters ones, most of the balloons used were 7 millimeters. Because maintaining AVG's secondary patency requires repeated expansion, so many of our AVGs are lasting 4 to 5 years, with some at 7 to 8 years and several beyond 10 years. Recent follow-up shows some are nearing a decade of use. Therefore, as you can see, the distribution here is quite even, including cases with 1, 2, 3, and even 5 or more interventions. Judging from the characteristics of the lesion, we can see that AVF has Chinese characteristics. Most of our cases are radiocephalic fistulas, with lesions predominantly located at the anastomosis and the puncture sites. As mentioned earlier, the lesions of AVGs are mainly at the venous anastomosis and the puncture sites. The 6 months data shared previously were actually quite positive. This time, we reviewed 1-year data, and I personally believe they are still quite acceptable. In my opinion, the results are already very good, certainly better than with conventional high-pressure balloons. The 6 months patency is close to 80%, and the 12 months patency is close to 50%. Moreover, the outcomes between the stenotic and thrombotic subgroups showed no significant difference. When subgrouped by stenosis and thrombosis, the results remained largely consistent, comparing AVF and AVG outcomes. AVF appears to perform better, as the curves gradually diverge. Although the p-value did not reach statistical significance, the p-value is 0.0515. With further follow-up or a larger sample size, AVF might demonstrate a clear advantage. These outcomes similar to the high-pressure balloons. AVF dilatation yields better results than AVG. The dilatation effect of AVF is equivalent to that of high-pressure balloons and is superior to that of AVG. Well, I think it doesn't matter because if a single dilatation can maintain patency for 6 months to a year, these data are very promising in my opinion. Achieving longer patency with current technology remains challenging. Therefore, I personally believe that regardless of statistical significance for both AVF and AVG, using a high-pressure scoring balloon can achieve relatively good primary patency at 6 and 12 months. On another note, for AVG cases, our center actually performs PTA on a relatively high number of AVG patients. So, what we also want to know is, for this specific balloon, which site in the AVG yields better outcomes? For instance, which balloon should I use for the puncture site and which for the outflow vein in the future? We actually aim to refine balloon selection. However, it is indeed a pity that we categorize the lesions and patients into different subgroups. After comparing, we found that there was truly no statistical difference in patency among the various case types. We further compared the two most common lesion sites, the puncture site and the venous anastomosis site. But there was still no statistical difference in patency. Nevertheless, this indirectly demonstrates that DKutting balloon is capable of dilating any site in an AVG. Its expansion effect is basically consistent across locations. For AVF, however, the situation is different. It is not feasible to stratify lesion sites into many categories because there are many combined lesions, especially in AVF, making such certification difficult. Therefore, we can only compare single lesions. We compare the puncture site with the anastomotic site. No, not the puncture site. We compare the venous outflow tract with the anastomotic site. It can be seen that, in fact, the puncture site, its patency is obviously better. Compared to the outflow tract, the difference is statistically significant at both 6 and 12 months. But you can actually see that the patency for the puncture zone is about 85%, and it is about 65% at 6 months and 12 months. If I recall correctly, the 6 months patency for AVF is 79.92%. The 12 months patency is 53.89%. So among all AVF lesions, puncture zone lesions yield better outcomes. Therefore, based on our retrospective data, especially for AVF puncture site lesions, the DKutting balloon may deliver superior results. The previous analysis included cases using the balloon alone as well as in combination with other balloons. We selected cases treated with the DKutting balloon alone for analysis. After using DKutting balloon alone, we wanted to verify whether cases with good immediate results also maintained good primary patency. Out of a total of 179 cases, thrombotic cases were just 8 cases, too few, so they were excluded. Then 171 stenotic cases remained. Overall, the outcomes were consistent with the results from the entire cohort. Then the primary patency can still reach 80.72% at 6 months and 50% at 12 months. Let's check AVF and AVG separately again. The results are essentially the same and without statistical difference. Therefore, although this is a retrospective study, we infer that if a case was considered suitable for the DKutting balloon and the immediate outcome was acceptable, only then was a patient included in the cohort. Otherwise, a stent might have been placed, or surgical intervention performed, or another balloon used. It is certainly possible. Only then did we go on with further observation. As long as the immediate morphology was acceptable, the primary patency at 6 and 12 months for both AVF and AVG remained fairly good. Let's look at the characteristics of lesions treated with the balloon along the lesion locations and types for both AVF and AVG are, in my opinion, largely consistent with the overall case numbers and types discussed earlier. So what follows is to say, I truly believe that the strategy for lesion assessment might remain unchanged, but as more evidence accumulates in the future, the treatment strategy might indeed change. It is not necessarily that we always start with high-pressure balloon, and only if that fails do we consider focus force balloon to achieve dilation. I think the old point of view need to be gradually updated. Another interesting point we've been discussing over the past 2 to 3 years is that we want to dilate stenosis into aneurysms, or at least we won't be limited by the reference vessel diameter. We just need to think about how large we want to dilate the vessel. This has led to the use of oversized balloon dilation. For dilation using our oversized balloons, we typically employ a focused force balloon as the initial step to pre-dilate the lesion, followed by sequential upsizing with larger balloons for incremental expansion. This is our standard approach. I've shown this image on many occasions. It demonstrates the outcome after dilation. Ultimately, using a 10 millimeters balloon, coincidentally, some of these data fall within the subgroup of our study. Let's examine whether oversized balloon dilation truly offers benefits. Does using DKutting for pre-dilation and a larger balloon for post-dilation yield better results? Better. The primary patency at 6 months reached 81%, which is statistically superior to the previously mentioned. Overall, after upsizing the balloon diameter, for example, to 10 millimeters, the 6 months primary patency reached 90%. Further upsizing to 12 millimeters at 12 months did not show additional benefit with a larger diameter. Thus, the 12 months outcomes were similar. Therefore, from our retrospective study, it appears that force focus, after using the DKutting balloon as first line, combined balloon therapy with sequential, stepwise high-pressure balloon dilation, may still benefit some patients. For instance, sizes up to 8 millimeters or even 10 millimeters might be acceptable, but 12 millimeters may be unnecessary, as increasing the diameter did not significantly improve patency. This is a case example showing pre- and post-dilation using a 10 millimeters balloon. Does the number of prior dilation affect patency? Let's look first at the AVF group on the left. From left to right, we can see cases with no prior dilation, 1 prior dilation, and 5 or more prior dilations. At 6 months, there is essentially no change. However, looking at patency at 9 and 12 months, if the number of prior dilations is 4 or more, the patency at the 9 and 12 months may be affected. Let's look at the case of AVG on the right. In fact, it is the same as the case on the right. Blue represents 6 months, yellow 9 months, and green 12 months. AVG does not show this pattern, which allows us to speculate. For AVG, each lesion's characteristics and severity are likely similar. Even after dilation, they probably remain similar. No matter how many times you have intervened, as long as no big mistakes were made or significant progression occurred, the outcomes at 6, 9, and 12 months are largely consistent. That is basically the pattern. Also, we found a very interesting phenomenon, which seems to be similar to what we originally thought with prolonged use. Could an AVG become more like an AVF because tissue might gradually cellularize with cells creeping into the pores of the epithelial graft like worms growing inward? At both the arterial and venous anastomosis, endothelial cells and other tissues grow along the anastomosis into the graft. The puncture zone, after repeated punctures, becomes full of holes. After these holes form, tissue grows vigorously into them. Eventually, the puncture zone might resemble a pseudoaneurysm, even losing the original graft structure. As time goes on, is it possible that an AVG becomes more like an AVF? The closer an AVG resembles an AVF, the better the response to PTA in theory, and it is a relatively large caliber AVF. Let's look at the 6-month univariate and multivariate analysis for AVG. Leaving the left univariate analysis aside, in the multivariate analysis, the age of the AVG axis indeed emerged as a protective factor. It can be seen that the longer AVG has been used, the better the outcomes of PTA, in my opinion. First, as I mentioned, this study is retrospective. We can analyze it on our own. Second, the longer an AVG is used, the more it resembles an AVF. Third, I think short-term AVGs are prone to frequent occlusion. Some demonstrate poor postoperative outcomes and are likely to fail within 1 to 2 years. Either you would get a new one or choose another access. Those that remain are the healthier ones. I think it might be like this. We indeed derived a result, 22 months, surviving past 22 months with an AVG. Or put another way, an AVG that lasts over 22 months becomes more durable and more suitable for PTA. This is derived from our retrospective results. We can see that using this cutoff to divide the groups, AVGs older than 22 months showed a 6-month primary patency of 83%, significantly higher than the 60% for those younger than 22 months. Retrospective studies certainly have many biases, and this is undeniable. We acknowledge this. The bias mainly relates to patient selection, particularly operator selection bias for cases. But I think this can be viewed from 2 angles, to be blunt. If the operator is relatively inexperienced, case selection might not be very rational. This bias is negative. If the operator has relatively more experience, this bias might actually be positive. For example, if I correctly identify the lesion and made the right judgment based on it, whether it is more suitable for endovascular treatment or surgery, unless we select cases more suitable for endovascular treatment and appropriate balloon, it may not lead to good outcomes. I think this kind of bias is actually positive and correct. This suggests that in future prospective studies, we should reference these findings. Cases clearly unsuitable can be directly placed in the exclusion criteria. For prospective studies, our inclusion criteria can also reference the indications from this retrospective study. Give it a try. I think it holds certain significance. Let's discuss which cases we did not include besides those already mentioned. For example, in AVF, valvular lesions we consider unfavorable, such as cases with thickened, tortuous, or significantly sclerotic valves, and cases where senior operators clearly believe PTA outcomes would be poor. These cases would not yield good results when using DKutting, so they should not be included. The outcome would be poor post-procedure, but you can't blame the balloon's performance. You can only attribute it to problematic case selection. Also, for example, in AVG venous anastomosis sites with obvious flow-limiting hyperplasia, especially against the blood flow direction, these cases might require stenting or surgery. PTA outcomes won't be good, so we also did not include them. Also, cases with extremely prominent hyperplasia, like this, where using a high-pressure scoring balloon like DKutting cannot fully exert its effect. Its pressure isn't as high as CQs, and its blades score the intima. If the intima is too thick, it cannot achieve cutting or scoring. So for such cases, we either perform surgery to clean it out thoroughly, or we use extremely high-pressure balloons, which I think is also fine. For instance, when 40 atmospheres of pressure is indicated, we can simply use the CQ balloon. It effectively compresses the hyperplastic tissue against the vessel wall or achieves floor position, which yields a good result. There is no need to employ the DKutting balloon in such cases. So what I really want to say goes back to previous viewpoints. When we encounter a case for PTA, we first use the first line option. We start with a high-pressure balloon. If the outcome after dilation is acceptable, we leave it at that. If it doesn't dilate, then there are second-line balloons. But maybe in the future, I think this view may change as our evidence increases. Because indeed, many centers, including the increasing use of focused force balloons, especially those increasingly designed for vascular access, are applying them in access interventions. We may get more and more evidence, more and more positive evidence of this. Perhaps in the future, at some point, we will incorporate it, possibly first in a consensus. Our first step is to start with a focused force balloon, either for direct one-stage dilation or for predilation as a first line. Let's review the summary of what I just presented. In our single-center study, the DKutting balloon indeed achieved a relatively good primary patency at both 6 and 12 months for both stenosis and thrombosis, and for both AVF and AVG. It was superior to previous POBA treatment. Besides, from a lesion location perspective, for AVG, since D-cutting can essentially handle any site, there was no difference between sites. For AVF with more categories, the puncture zone might yield superior outcomes. Using the DK balloon alone seems to yield patency outcomes consistent with its combined use in the overall cohort. Using the decutting balloon for predilation and an oversized balloon for postdilation, I think based on our retrospective study shows some positive results for primary patency, but it is not saying that larger balloon diameters yield better outcomes. Our results indicate that 8 mm and 10 mm are acceptable, with 10 mm yielding the optimal effect. Beyond 12 mm, the effect may not be so good. We observed an interesting situation, the lifespan of AVG. The age of an AVG seems to be a protective factor for PTA. And we derived a cutoff value after 22 months. AVG might become more durable and more suitable for PTA. Once again, thank you for the invitation. Okay, thanks.